So, a very good afternoon from the Department of Pediatrics, Unit 1. We shall be presenting a clinical grand round in the specialty of pediatric rheumatology. And I think we haven't done it in many years. But before we begin, I would just like to tell you about the history of pediatric rheumatology services in the department. It all began sometime in 1985-86 when one of the senior residents, Dr. Gurkipal Singh, and the then Professor Wimbles Hay, who also retired as the head of the Department of Pediatrics, they initiated the pediatric rheumatology services, and which were gradually, supplemented by the efforts of Dr. Sushil Kabra, and we are very fortunate to have him here. He is also retired as the head of the Department of Pediatrics, and also Dr. Rakesh Loda, who kept on doing the pediatric rheumatology and providing services to these patients along with their own specialty, which is their pediatric pulmonology and intensive care. And in 2016, when Dr. Narendra Bagri joined the department, he was given the responsibility of pursuing pediatric rheumatology as a specialty. And since then, a lot of things have been done, and this specialty shifted into Unit 1. And today, we'll be talking about presenting childhood inflammatory arthritis. So he'll tell us about the progress that has happened in the last 8 to 10 years and also what has been done in the previous years. So I'll now invite Dr. Narendra Bagri to take over the proceedings and present the CTA.
Thank you, sir. It's my pleasure to do the inaugural presentation and the inaugural CGR for pediatric rheumatology from the department of the unit. So this is how we are going to take you through the next 1 hour. To begin with, since it's a clinical grand round, I thought that we'll put the picture of a child who is being referred to us with arthritis. I'm not aware what exactly treatment he's receiving, but for sure during the course of treatment, the presentation will look into what is happening around. So this boy, by the time he reached to us, we can see that he has fixed contractures. He's almost like a logbook kind of thing. And despite receiving the treatment that is being shown, and also common myth that this could be tubercular arthritis. So the journey of pediatric rheumatology, as Pankaj Hari has highlighted, it began way back in 1985 with the visionary leadership of Professor O.P. Ghai, who had a trend of establishing the subspecialties in the department. And I would like to take this opportunity to thank the Department of Pediatrics, in particular the senior colleagues, for nurturing an environment of development of the subspecialties. So this was then 1996, Professor Kabra and team reported the first series of paper with 300 patients of GIE at that point in time known as juvenile chronic arthritis or GCA. And then subsequently, Professor Rakesh Ludha also joined, and for a short stint before I joined, Dr. Nija was also there to support the services. And since then, we have moved further. And here is today's topic. We are going to discuss about the huge differential cause of childhood arthritis. So if we look at that, I think it's a huge domain where there are plenty of causes of childhood arthritis or joint pain. But for today's presentation, we will be focusing on what is known as juvenile idiopathic arthritis. And if you look at this, this is the most common cause of pediatric rheumatic disorders. And this typically affects girls more than boys in our setting, where the subtype of GIA, which is ERA or the enthesitis arthritis, is most common. It affects boys more than this. So it's basically a chronic form of arthritis, which typically affects kids more than 16 years, and the chronicity is defined as a duration of more than 6 weeks. And of course, the diagnosis of exclusion. So we can look at the evolution of the classification, and we can see that the first description of 1959, when it was known as Still disease, it has evolved, gone a long way, and as per the latest classification, the classification has been changing over the time depending on our understanding of the disease. And at present, we classify the disease in systemic GIA, either it is rheumatoid factor positive GIA or rheumatoid factor negative GIA or early onset ANA positive GIA. And I will, in the subsequent presentation, I will let you know why these entities are different. So this is a nutshell about, in fact, GIA is an umbrella term which encompasses the host of different forms of at least subtypes of GIA. And the most common subtype in our setting is the enthesitis related arthritis, which is characterized by the presence of typically it involves the axial skeletal and an adolescent boy walking with an asymmetrical joint involvement below the diaphragm, provided the diagnosis is ERA. Then the other group which is more common in our setting is systemic onset GIA, and as the name suggests, in addition to the arthritis, it is important to note that these patients can also present without arthritis because the inaugural presentation can be systemic features only like fever, rash, and arthritis. And these patients have other systemic manifestations like organomegaly. The other forms of arthritis is oligoarticular GE, which is typically ANA positive and has higher risk of developing uveitis, as we will see. So looking back into this, why these different subtypes, why do we have a heterogeneous classification in GIA unlike adult rheumatoid arthritis? Probably there is a biomechanistic mechanism behind this, and to understand this, we did a proteomic study with the help of Professor Velpandian. Thank you for joining us, sir. So basically, we did this in different subtypes of GIA. 16 subsets of 16 patients from each of the following categories of GIA were the synovial fluid. We thought that this is the most proximal fluid, which will give us the most better clue of the underlying pathophysiology. And we control the synovial fluid proteomic expression with the control. And control here were non-inflammatory conditions. For example, a child being operated for dislocation of hip or something like that. So when we analyze this data, we can see that the different subtypes of GIA, we can see in the heat map that they have differential expression of proteins in the various subtypes of GIA. So this has the pathogenic mechanism why these behave differently, and probably the end result, although is the arthritis in these particular subtypes or different subtypes of arthritis, but as we can see, the differential protein expressions are different in different forms of GIA. And during the subsequent course of presentation, I will let you know that then some of these proteins have come on the bedside, whereas, for example, the protein S and protein S119, which is known as MRP814 or calprotectin, has come to a bedside use for the diagnosis and prognosis of GIA, particularly systemic onset GIA. Moving further to our data, so this is the last nearly 10 decades data where we have enrolled around 1,022 patients of juvenile idiopathic arthritis, and 63% of them are boys, and the age at diagnosis was around 10 years, and the duration of symptoms was 9.5 years. And as we can see, the most common subtype of GIA in our setting, by R I mean that Southeast Asia region, is the ERA or enthesitis-related arthritis, which is in contrast to the Western world where the oligoarticular GIA is more common. And for those who want to know what exactly ERA is, this is the classic presentation of ERA where in addition to arthritis, these patients will have typical features of enthesitis, which is nothing but the inflammation at the site of tendon or ligament attachment, along with the midfoot tarsitis. So GIA is basically a clinical diagnosis, but we often need lots of investigations which will help us at least to rule out some of the important differentials. For example, hemogram is important, and to put the context together, I would like to say that at times sinister causes like malignancy can have an inaugural presentation. In 20 to 30% of the patients may have arthritis as inaugural presentation, and in that regard, the presence of the common hemogram can help us differentiating GIA from sinister causes like malignancy. In addition, we need to get the inflammatory markers like ESR and CRP for assessing the disease activity, and of course the liver and the renal function test for disease and drug-related side effects. So the complications, we will have to look for the macrophage activation syndrome and certain set of autoantibodies, which I'm thankful to the Department of Rheumatology for helping us out with carrying out these investigations where we can see the rheumatoid factor or anti-CCP, and the middle picture is showing ANA and the presence of which is associated with uveitis, and HLA-B27, which is present in 80 to 70% of the cases of ERA. So this is one of the paper where we have done, our unit has published in anti-CCP presents, and it has just reiterated the fact that it's a more aggressive form of arthritis in children. So now coming to taking it further, I will invite Megha to have a take it further.
Thank you, sir. So monoarticular arthritis is a diagnostic odyssey. More often the children are misdiagnosed and mistreated as tubercular arthritis. Such a similar presentation in an 11-year-old boy who has left knee arthritis for last 1.5 years. The child was treated with anti-tubercular drugs and also undergone surgical interventions like synovial biopsy without any evidence evidence, he was treated with anti-tubercular drugs, and following which the child has no response, and child lately present to us. At that time, the child has already developed such damages, like he developed anterior uveitis with 70% of the vision loss, along with a large scar over the knee, which remains there for a longer time. We had done a study enrolling about 53% in a cohort of these patients. Around 54% of the children are primarily diagnosed as tubercular arthritis and were managed with anti-tubercular drugs. 9% of them has developed fixed deformities. 13% were undergone orthopedic interventions, and there was a diagnostic delay of around 18 months. Further, the other joint involvement was found in 22 patients. Apart from the clinical evidence, histopathology and radiology also plays a very important role in diagnosing juvenile inflammatory arthritis, more importantly, in ruling out the other causes. So I would like to invite Dr. Rasid sir from pathology. He will be discussing about histopathological findings in JI.
Thank you, Dr. Nigar. So, in rheumatoid arthritis, usually we see synovial hypertrophy, and if you see here the slide, here you can see the slide, a lot of inflammatory cells. So, these inflammatory cells are basically they are lymphocytes and plasma cells. These are plasma cells and lymphocytes. In addition, we see vascular proliferation, then hypoplastic cell proliferation. But when we see, in addition to chronic inflammatory cells, which are lymphocytes and plasma cells, polymorphs, there are cells which are these cells, polymorphs and histocytic cells. The picture becomes a little complicated because whenever we see these acute inflammatory cells, or in terms of pathology, we call it activity, then we need to rule out whether there is any infection like tuberculosis, or if it is rheumatoid arthritis, whether it is complicated by any bacterial infection. So basically, when we see chronic inflammatory cells, primarily lymphocytes along with large number of plasma cells, without any granuloma, necrosis, or giant cell, it favors rheumatoid arthritis. But it cannot exclude because sometimes the biopsy, when you take biopsy, there may be some limitation. Maybe the granulomas are there somewhere else. So further investigation, clinical correlation and radiology correlation, which are important. Thank you. I would like to request Nisha to discuss about the radiology.
Thanks, Dr. Singh. I will start with taking a cue from Megha. Monoarticular arthritis, as it is an enigma, clinically it is same here in radiology as well. Most of the time, whether it is infective, that is most commonly tubercular here, or CIT, that remains a diagnosis. So we analyzed retrospectively some children who had conclusive proof of either of these two, and analyze the imaging parameters. So, although there was, in most of them, there are some subtle clues which way it goes, like the synovial thickness is usually more in TB arthritis, but it is uniform. And associated necrotic lymphadenopathy, as commonly understood, is found in TB arthritis as compared to JIA. But in real life, it is really difficult to differentiate between the two. Now, these are a few examples of how did we differentiate between these two. So this lower panel depicts the TB arthritis, where we could see this is the elbow-joint tuberculosis, where there is necrotic lymphadenopathy anterior to it, and we can see if the synovial enhancement is seen, it is very thick and irregular, along with cortical bone erosion over here. In contrast, if we see the JIA picture, there are areas of marrow edema which is involving the epiphysis and the pre-epiphyseal region, whereas the enhancement is pretty smooth. Coming to the imaging modalities that we use in imaging in pediatric rheumatology, ultrasound is the first and very versatile imaging modality. It can it can give a lot of information about the synovial fluid, the synovial thickening, the nature of synovial thickening, the vascularity. So if we see this kind of vascularity on Doppler, it indicates that it is probably an active synovitis, whereas we are seeing synovial thickening, but there is no increased vascularity. Probably it is an inactive or chronic synovitis. And an addition to this is nowadays we can use contrast enhanced ultrasound as well to see the vascularity of the synovium, and in order to see it can act as a surrogate to contrast MRI in all cases, which we know that resource is limited. Tenosynovitis is again very well picked up on ultrasound as well. Here in this lower panel, we can see that these are the tendons which are seen as echogenic structure, and this is the tendency which is showing Doppler signals. Normally, they are usually without any signal. So we evaluated these children with polyarticular ZIA, in which we saw that addition of ultrasound as like in OPD setting when they are clinically evaluated, it actually adds value to the clinical examination. MRI, most often we resort to MRI as a problem solving tool, the go-to modality, but the main disadvantage is the need for sedation and the long time and of course availability. So for the imaging, initial MRI evaluation, it is required for establishing diagnosis and excluding mimics. Axial joints like SI joint, which is not that well evaluated on clinical examination alone, that is one important area where MRI scores over clinical examination alone. So this axial image, it shows that in the T2 fat sac image, we can see that there is hyperintensity involved in the left sacroiliac joint along with adjacent bone marrow edema. So this is suggestive of left sacroiliitis. Also, in cases of detection of complications, as we can see here, this is atlantoaxial dislocation in a chronic case of ZIA, where you can see the distance between the atlas and axis has increased and there is an impingement of the disease damage assessment and monitoring disease activity and detection of complications are other indications of MRI. In ERA, which as Dr. Bagri has said, is the main subtype in this subcontinent. In this, sacroiliitis is one of very common or it is a predictor of persistent active arthritis in ERA. And for sacroiliitis detection, MRI with or without contrast definitely scores over clinical examination alone. So in these images, we can see actually the images are coming black, quite black on this, but you can see on the side panels. So on the left, sacroiliitis, we can see here, you can see multiple bones, bone marrow edema. And this is actually the imaging picture of enthesitis, where there is inflammation and edema at the insertion site of the muscle side tendons. And this is one study of ours which we did for prediction of relapse in clinically ZIA patients who are in remission. So we evaluated whole body MRI for that purpose and detected the presence of synovitis, bone marrow edema, tenosynovitis, sacroiliitis, enthesitis. And so these are the total 30 children were included who were in remission. So just immediately at the time of stopping the drug or tapering the drug, there was a whole body MRI which was done. After that, the children were kept on follow-up and clinical follow-up followed by evaluation of the data. What was the imaging finding at the time of stopping the drug? And we saw that synovitis on whole body MRI was a strong independent predictor for disease relapse in these children. While diagnosing, we should also keep in mind, especially in monoarticular arthritis, several mimickers which may mimic arthritis, but actually they are not. Like pigmented villonodular synovitis, which is a condition usually monoarticular involvement, but on imaging we can get a clue if we see hemosiderin deposits as shown here. This is one dysplasia which is actually which mimics deforming arthritis with painless contracture formation. This is known as progressive pseudorheumatoid arthropathy or dysplasia, where there is expansion of the distal metaphysis of the proximal phalanges along with characteristic spinal changes. During in imaging, we follow this kind of protocol that if it is polyarticular or oligoarticular GIA and it is consistent clinically on with GIA, then MSK ultrasound is the common thing that is done. In cases of sectoiliac joint involvement or spine involvement, we resort to MRI and follow-up imaging as per clinical description. If it is a monoarticular arthritis, it is most often a dilemma. We have to resort to a multimodality approach. And in order to spreading awareness for this relatively less talked about entity, we are in process of publishing this mini symposium in our radiology journal. So over to you, Dr. Bali.
Thank you, Dr. Manisha. So now I will take you through, once we have diagnosed juvenile idiopathic arthritis, we need to treat the patient, and this is how over the next few minutes I will take you how our team works in tandem to treat these patients. So it's a multidisciplinary approach, and to begin with, I would like to engage the house to pay tribute to this legendary figure, Professor Subba Rao, who basically has done a pioneer role in innovation of methotrexate. And just to bring the context together, I mean, he discovered this for the children with acute leukemia, and then it comes to the practice of rheumatology. So methotrexate is one of the drugs which is often used by those who are practicing rheumatology. So broadly as discussed, we have classified the patients into these various subtypes. The systemic GIA is one subgroup, and the non-systemic GIA have been clubbed together for the ease of administration and drawing out the management guidelines. So this is what we follow in our unit, and this is typically all patients will get naproxen, and methotrexate is the first line or the preferred drug that we will use, and sulfasalazine is preferred in cases of ERA or sacroiliitis. Subsequently, if the patient is not responding to this particular group, the conventional DMARD, then we will consider biological agents, either anti-TNF, which is etanercept or adalimumab, 3 months down the line, because usually 10 to 12 weeks is the time when the methotrexate will start working on. And in between that, we will also consider using intra-articular corticosteroid as and when required. So in contrast to the systemic onset GIA, non-systemic onset GIA, the systemic onset GIA is, as I told you in the beginning slide, that it's a more of a systemic disorder. And apart from joint arthritis, there are other systemic features. So to tame down the heightened immune system, we will often have to use the intravenous methylprednisolone to begin with, and then tapering doses of steroid down the line, which has to be tapered over the next 6 months to a year, depending on the clinical response. And in addition to that, they will also require methotrexate, or in resource poor setting, leflunomide and cyclosporin has been used with some vague evidence. And in ideal world, we will also consider using biological agents, either IL-1 or IL-6. IL-6 is what is available with us, that is tocilizumab. In ideal world, we should start with right from the beginning, but what we follow is usually we start with a dose of steroid and methotrexate. If the child doesn't respond, then we'll go ahead with biological tocilizumab. So this is one simple procedure which probably, if you can recollect the case which Megha presented, was undergone lots of interventions, but actually that patient was requiring the simple procedure of intra-articular corticosteroid, and they are being used on and off whenever we have limited number of joint flares. For example, typically we will use it when the number of joints involved are less than 4 in any sort of arthritis. And the usual agent intra-articular steroid is triamcinolone acetonide, which is available in India. And this is one of our study where 53% is the reported improvement in inflammation functional status after using these agents. This is in contrast lower than what is reported in Western literature, probably because of the type of the steroid that is being used, because triamcinolone acetonide is what is used in their setting in contrast to triamcinolone acetonide, which is used in our settings. So as I have told that it's a disease which will keep on progressing, and to begin with, the first drug is methotrexate, but as there is an evolving concept that we need to hit the disease early at the very onset. And in this attempt, we probably what is known as early aggressive therapy, or to treat the disease when there is window of opportunity so as to limit the disabilities in this context, because biologics, though are they effective, but still we need something to search on. And in that regard, our unit was using a pulse dexamethasone therapy for a long while, and we thought that let's do it a randomized controlled trial and see the effect. So the objective of this study, which was done by Umang, who has been my first thesis student. And the objective was to evaluate the efficacy and safety of pulse dexamethasone therapy in children with GIA who are treatment naive. And this was a double-blind randomized controlled trial. And the primary outcome of the study was to look at the ACR pediatric 70 response at 16 plus minus 2 weeks. The inclusion criteria were the kids who were heavy disease burden as characterized by more than 5 joint involvement or who have any hip or cervical spine joint involvement irrespective of the total number of joint count. Those who had received a prior steroid or received prior DMARDs in the preceding 12 months are excluded from the study. And the intervention was to give either pulse dexamethasone or placebo. Again, thanks to the Professor Velpandian, who has helped us in making these placebo and identically looking dexamethasone. So we enrolled around 60 patients, which were randomized to both arms, the dexamethasone and placebo arm, and were analyzed as per intention to treat analysis. And these are the key findings. So what we find is that probably the study did not support any use of pulse dexamethasone at 16 weeks as compared to the placebo. We see that the ACR 70 response was comparable in both the arms. Though this was a negative study, but still there are certain clues. What we have, the reflections on the paper is that probably we looked at the overall endpoint at 16 plus minus 2 weeks, which may be too late to assess the effect. But you and we know that, particularly those who are in rheumatology, will see that you give depomethylprednisolone injection to the patient and next morning he starts walking. So we probably didn't look at the early response. That was one thing. And other possibility of this negative result might be the study population, because the most common subtype of GI in our study is ERA, in contrast to maybe that might have played some role. But having said that, how the world has moved as far as steroids is considered, so the statement of the recent American College of Rheumatology guidance suggests that the long-term use of steroids, I mean by long-term, should not more than 3 months, is absolutely probably they are recommending against the long-term use of systemic steroids in non-systemic GIA. This is not about systemic onset GIA. And but still the question is on, and there are ongoing trials going on this, I mean, an affordable drug for managing steroids. Moving further, I mean, we have discussed that methotrexate is one of the important drugs being used. We have discussed that steroids are being used, and let's see how much response to the methotrexate, how many of the patients will respond to methotrexate. We don't have anything on the table as I was talking about. Let's decide that if the patient comes to you on day 1 and we can decide that he will going to respond to this or not, you have to take the advantage of the window of opportunity. And in that regard, we planned this study and looked at the serum MRP-814, and if you can recollect from the first slide of the proteomic signature, this particular biomarker is elevated in various subtypes of GIA, in particular systemic onset GIA, and we decided that we took these samples at the baseline and look at the response of the levels of MRP-814 after 6 weeks of the enrollment. And what we found after 3 months of the enrollment, and what we found is, so what we found that the baseline MRP-814 levels were higher in the responder group as compared to the non-responder group, and this was again found in the logistic regression model. So we conclude possibly the baseline MRP-814, or what is popularly known as calprotectin, might predict a response to methotrexate. And let's look at the recent literature about the MRP-814. So this is where our findings are in keeping with the other authors, that MRP-814 levels may be raised in patients who are going to respond to methotrexate. And then in addition to prognosticating the patient in terms of response to methotrexate, there is also a value added by MRP-814 where the high levels may differentiate it from other inflammatory conditions, particularly systemic onset GIA. So having discussed about the role of steroids and the conventional DMARDs, let's move on to the other group of drugs from the therapeutic armamentarium. I would invite Pavni to take it further.
So our understanding of GIA has improved over the years. We have identified molecular targets for pharmacological exploitation, and till date we have a number of biological disease modifying agents. In our practice, we are commonly using interleukin 6 and TNF inhibitors, the commonest of which are etanercept, adalimumab, and tocilizumab respectively. The earliest report of biological use from India from our unit is dating back to 2016, where we shared our experience with 10 patients, of whom 9 remitted in use with biologicals. Since that, we've come a long way and have collected data from our registry and from our unit biological registry, and have collated the data of 115 patients receiving biologicals with a follow-up exceeding 3 months. We have about 168 patient years of biological use experience with us. As was expected for our population, the predominant subtype of JIA in those who were on biologicals was enthesitis related to arthritis, and therefore the most commonly used BDMARs were TNF inhibitors, of which adalimumab exceeded etanercept, and then close second was tocilizumab for systemic onset JIA. We currently do not have IL-1 inhibitors in use. Again, cost is prohibited for these agents. Therefore, most of our patients, 86% of them, were supported by patient assistance programs, and very few were self-funded. The key point here is that our patients experienced a median delay of 12 months in diagnosis, and in rheumatology, as for other branches, access is therapy. So we had a median of 12 months from the time of symptom onset to diagnosis, which might have affected the active joint set presentation, which was quite high, 6 joints at presentation, as compared to the international cohorts, which we will discuss later. So the data key points in our observation were that we had a higher remission proportion. About 92% of our patients remitted as opposed to those reported in literature, that is 75 to 80%. This must be because of the predominance of ERA in our cohort as opposed to polyarthritis in international cohorts, which is much more notorious to be refractory to using biological demand and required. The other salient observation in our cohort was that the serious infections requiring hospitalization was a considerable burden, and particularly so for reactivation of tuberculosis, which has not been reported as much in the international cohort. So we conducted predictor analysis to predict the time to remission in these patients, and found, after analyzing these parameters, that macrophage activation syndrome at presentation was associated with a longer time to remission. Similarly, for flares after the stoppage of BDMARs, we found that a patient who took longer time to remit also had a higher chance of flaring after stopping of biological agents after the median period of 12 months of therapy. And for adverse events, as was the experience with literature, the duration of biological use, the use of tocilizumab as the BDMAR, and the longer time to remission were associated with increased number of adverse events. We conducted a comparison with international cohorts, and we found that ERA was a predominant subtype in our setting, and also we had a higher joint activity at presentation with a lower mean age at presentation. Uveitis and macrophage activation syndrome were considerably higher in our population, and of course, the stark difference was in tuberculosis reactivation. Despite screening and appropriate prophylaxis, we had a higher proportion of children flaring after use of biologicals, 3.4% to as low as compared to 0 to 0.7% in international cohorts. So considering this data, we realized that the need of the hour is to have a biologics registry, a national biologics registry, where we can conduct pharmacovigilance and a review of long-term outcomes in these patients, which can also ultimately guide policy, because access is therapy. So we have future promising prospects. Considering that BDMARs are very expensive, we have newer small molecule agents such as tofacitinib, JAK inhibitors, which offer the dual advantage of being of oral administration and of lower cost than the existing treatment. However, we need to explore this concept in a non-pharmacologically funded real-world scenario, and probably this will give us more answers as to how we can improve access to therapy and outcomes in these patients. While disease damage control is one part of the story, the other is to rehabilitate patients who already have sustained some damage. Therefore, I invite Professor Dr. Geeta Handra to kindly.
Thank you, Dr. Bhakti, for including rehab as part of the process. So, coming to the rehabilitation assessment, things which are very important for us is the acute or chronic duration, pain severity, stiffness if it is present, any temporary deformity or permanent deformity, heart, muscle, joint or bone health, and limb length discrepancy. Further, we also assess the functional status, where self-care activities are important, transfer and mobility, assessment for dependence, health-related quality of life. So all these things, after assessing, we go into psychosocial and educational history also. We try to assess whether the patient is having any issues, any concerns regarding any of the life changes which he is having. We also see the imaging, we see the available insurance, welfare cards, disability certificate requirement, etc. And the goals for management are basically, first is the pain management, next is the functional restoration, then prevention and correction of deformities, pre and post surgical care, psychosocial, educational, leisure sports, and vocational support for the patient. For research-based assessments, the main things which are important for us are the various scales and scores. Basically, for pain, like we have VAS score, we have rating scales, we have faces pain. Similarly, for the range of motion we have goniometers, muscle testing, dynamometers, and other types of assistive available devices which we use to assess the range of motion and muscle strength. They can be computerized devices also. Then for physical function, we have different types of functional assessment report scales like JAFA, CHAQ, JASI, etc. And health-related quality of life assessment scales are also available. Coming to the management, the physiotherapy management, there are some studies done in the Department of Rheumatology, the Pediatric Rheumatology, where they have shown that the physiotherapy management helps in pain management, exercises, prevention of deformity, patient education, and they give handovers and different materials to the patient also. In the pain management, we try to see how much effective is the treatment. Basically, if the biological NSAIDs and DMARDs are effective, then we don't have to go further. But we have certain modalities like heat therapy, which includes hot packs, wax bath, infrared, etc., cold therapy, deep heat modalities, electrical stimulation, etc., which are available to relieve the pain. But at the best is the relative rest. That is not too much of rest and immobilization with splints only on the part, not the whole person. In the cross-section study done in the department, we have found out that due to the juvenile arthritis, we have moderate disability and it profoundly affects walking ability. So basically, it has a moderate caregiver burden. So we should try to make the person as independent as possible and reduce the burden on the family. Principle of exercise therapy are basically relative rest. Basically, rest in the acute phase for not more than 2 to 3 days, and then start gentle range of motion exercises after pain and swelling is addressed. Start with isometric strengthening first because it doesn't affect the joint. And also avoid the stress to the joints. Don't stress over the inflamed joints and try to give them support. Body weight support is very important. So we have to maintain the bone health and body weight support plays a very important role. So try to keep the child as mobile as possible. Low impact activities like swimming, hydrotherapy can be started early. Modification of activities of daily living are explained to the patient. We have assistive technology available for the child or adult as and when required, like stick, crutch, walker. They improve gait and balance. We also educate the child about the adaptive equipment like built-up handles for the pen, for the spoons, or other modifications with splints. Lifestyle changes may be required in case of chronic disability, and he has to modify how he works and goes to the school. Home and environmental modifications may be needed. Leisure sports, workplace assessment, and suggestions are also provided. Other things which we provide are like for equinus deformity, there might be some equinus raise. For hand splints, we may give static splinting. We give footwear modification to support the painful foot and allow the person to ambulate. We give different types of splint to improve or correct the deformities or prevent further deformity formation for if the child's hand is affected, though it is less common seen in the children. Also, pre and post-surgical guidelines are also there. If you keep the muscle supple pre-operatively, you will have a better outcome post-operatively. So that has to be kept into mind. And weight bearing and mobilization should be started as early as possible post-surgically. And we have to give specific immobilization only to the joint. And restriction may be done as per the requirement for the specific joint. Post-surgical graded exercises are done with or without supportive plating, and this helps in improving the surgical outcomes. And timely surgery and post-surgical rehabilitation can effectively improve quality of life of patients with GIA under remission. Coming to the
patient in the ideal world, patient should not reach to us with the severe deformity. And when the patient comes to us, patient often requires surgery prior to the growth plates closure, which present risk to the development of the leg length discrepancy. And young patient may have difficulty in comprehending their surgery and rehabilitative requirement, and with the difficulty in managing the pain, leading to the potentially poor outcomes. First and foremost requirement is the prevention of deformity development. So arthroplasty in the young patient, as we know, is technically challenging and longevity is poor. So we apply bilateral traction, which may be useful to prevent the deformity. Up to 10% of the body weight can be applied. It reduces the pain and prevents the contracture. If the arthritis develops, joint should be fused in the functional position. Second, we can do is manipulation under the general anesthesia. A trial of this can be given for the pain relief, reducing the inflammation, thus providing symptomatic improvement. Intra-articular injection is given and then manipulation is done under general anesthesia setting. Maintaining the patient function is the foremost important. And we can do soft tissue release. This is considered in the children with severe functional impairment around the hip and knee. It can be combined with a partial synovectomy for the knee to improve functional outcome. If the contracture is there in the hip, so tenotomy of adductor muscle, psoas muscle and rectus muscle can be considered. And if it is there around the knee, so hamstring, tenotomy, gastrocnemius and opening of the joint capsule can be considered. Total hip replacement. It is indicated with the severe pain and limited range of motion due to joint destruction, which is late presentation to us. Arthroplasty, it remains the last resort for the patient. Most frequently performed around the hip and knee, but it has also been described for the shoulder, elbow, and ankle joint. It is avoided in the children as there are many difficulties. Technical issues are there, distorted and complex anatomy, high risk of failure, and possibility of revision due to limited longevity. So, in Western world, the mean age of the joint replacement is 26 years. But in our case, we operated this patient, which is referred to us by sir. It was enthesitis related arthritis. He was 28 years of age. We did the total hip replacement. The challenges in this case were like complex and distorted anatomy. In the children, there are excessive femoral anteversion, bone quality is poor, and generalized underdevelopment is there, and availability of implant is also an issue.
Thank you, Raj. And I have taken your words very seriously that they should not ideally reach to you. And hope the next time when we did the CGR, I would request, I would assume that the orthopedic team particularly can reach well in time so that they are. Thank you so much for joining, sir. And I mean, next time, 10 years down the line, I really don't want you to be busy with these surgeries. And I'm speaking this from my heart. So let's come to the fact that disease damage in juvenile idiopathic arthritis. We have heard that arthritis is an important cause of disability among children. So what is the impact of this in children? And to this, Roxana, student who's here, has done this study. And in this study, what we have found is that among the 105 children, around 50% of the kids had articular damage, and the critical joint involvement is around 1/3 of the patient. Just hold on for a while that I will let you know what exactly the critical joint mean in next couple of slides. And my colleague from ophthalmology will deal with the extra-articular manifestation, the uveitis, which is most common. And despite that, we can see that around 34% of the patients are still having inactive disease. So what's the lesson? We can see that the damage is around 48% in contrast to Greek or Singapore, which is around 6% or 5% of these patients. And by damage, I mean any sort of articular damage. And this might be because of ERA or biological use this sounds to a more plausible reason, as we can see that 36 to 44% of patients in their cohort are on biological, in contrast to only around 11% of patients in our cohort. So we did logistic regression and we found that the rheumatoid factor positive ERA and the increased disease duration were associated with disease damage in univariate analysis. However, in multivariate analysis, rheumatoid factor positivity or anti-CCP were associated with increased disease damage. So I would invite Dr. Rohan from ophthalmology to discuss about GIA uveitis, which is an important complication of juvenile idiopathic arthritis.
Thank you, Dr. Bagri. Good evening. So, as Dr. Bagri has shown that this disease not only involves the joints, but a large portion may also develop uveitis, which also, if blinding, can be a major cause of morbidity. And so this requires a lot of coordination between the two departments. And earlier it was being done by Professor Pradeep Venkatesh, Dr. Shaurya, and Professor Lodha. And in between COVID happened and things got a little stopped. But now I'm very grateful to Dr. Bagri because he has taken out special time and he comes to our uveitis clinic once a week. And that is a big help for co-management of the patient, especially now that many of these patients are also on these biologic agents. So that helps us a lot. And we also send one resident to their clinic. We have placed a slit lamp there where they can screen for uveitis. So this is something what a child with visual impairment can see. They might have scleroma, they might have overall decreased vision and can be a lot hampering. So just to show you some of the signs, so many of these children actually are asymptomatic. They may not have a red eye, they may not come with pain, and that is why we need to actually screen for them. We need to send someone to their OPD where we have a slit lamp and can screen them. So some of the pupil, you can see some of these dots floating in front of the pupil. These are actually cells in the anterior chamber which we can detect, and that can quantify the amount of inflammation and accordingly guide our therapy. And some of these children also can develop posterior segment manifestations in the retina, some amount of macular edema, disc edema, and we have seen some, these are again wide field retinal photographs with some patches of depigmentation here which can be suggestive of peripheral choroiditis as well. So like I said, it was originally initiated earlier, and now what we are doing is that we are running a conjoint clinic where Dr. Bagri comes to our UPD, and we also send one resident on one of the days to their clinics. And the aim of this is for early detection of these patients and appropriate treatment and to reduce the steroid dependence. So we need to reduce children who are being treated by more than even topical steroids, more than 2 drops, because that enhances the rate of cataract formation and glaucoma. And otherwise, those who require systemic, definitely also, like we said, not more than 3 months should be the time interval these days. These are some previous publications. So uveitis prevalence, and we have seen that it can be present in a lot of patients, it can be bilateral in a lot of patients. And some of these patients up to 60-70% were also having healed anterior uveitis, and some of these would also be with sequelae. So that is what we want to prevent. Visual impairment can be seen in up to 20% of cases. And another recent cohort publication from our side where most common was GIA. So this is actually the data of GIA patients out of the total. And so the recent experience over the past 1 year, we have seen about 67 patients, out of which 46 had uveitis, and GIA related uveitis was present in 16 of these patients. And now we've been also diagnosing other entities like Blau uveitis, where they have also done some genetic testing and identified these patients. And anthracite ERA related patients also have uveitis, which Dr. Bagri has been showing us. So less than 6/18 vision is what we call as visual impairment. And we have a lot of patients in this category, and less than 3/60 is which we call absolute blindness. So out of 67, even 8 patients are totally blind. And now these patients are being treated apart from methotrexate by biologics also. And Dr. Bagri has done this study where biologics was used alone without methotrexate, and they have also shown some good effect. But this is not, the data is not from RP Center. So before we go to this next topic, the only thing in for future what I want to say is that we want to increase this collaboration so that more and more of our children somehow are early on biologics to prevent the visual impairment. and also we want to study the effect of JAK kinase inhibitors in uveitis as well. Thank you.
Thank you, Dr. Rohan, for highlighting the extra-articular manifestation, in particular uveitis in GIA. So, continuing the damage story of GIA. So, this is what low bone mineral density and the Sushar has undertaken this work, and we have found that almost 50% of the patient has low mineral bone density as assessed by the DEXA scan. And we are trying the predictors, trying to develop a clinical nomogram so that we can rationalize the use of DEXA in our setting. And the important predictors are the subtype of GIE or systemic onset GIE, who often get steroids, is an important predictor, along with the increased clinical activity as assessed by the disease activity score and the functional class of the child. So, having discussed about the damage in various domains, including chiefly the articular damage, as we have seen that 50% of the patients or more will have articular damage. Few of them has required hip replacement at a younger age. And then we have looked at the uveitis, which is affecting around 1/3 of the patient, and many of them are visually impaired. So, coming to some of, if you can recollect the slide on the disease damage, I highlighted that 30% of the patients were having critical joint involvement, and by critical joint involvement, like I mean the joints such as cervical spine involvement or the atlantoaxial dislocation, which is an exceedingly rare presentation of GIA, but still it can happen once the disease is ignored for a longer time. Likewise, if you can see, this is thanks the team from CDR for joining. So this is a child who had, you can see that he is hardly able to open the mouth, and accordingly we can understand that the impact on the daily living, including the basic need of eating. And this is post-op, after which the child is improved. But again, these pictures are again showing the impact of ongoing chronic inflammation. And as I told for the orthopedic surgeon, I would also see that you are also relieved of these surgeries. So let's come on to, we have to, as of now, we've seen that typically GIA is involving joint damage, but they bite beyond joint as well. And if we see that if chronic inflammation persists, they can also lead to amyloidosis, which is again an exceedingly rare presentation of GIA in today's era. And if we see, there is one child with, we have in our cohort of 2 children with amyloidosis developing because of chronic sustained inflammation secondary to GIA. So this case report, we are actually trying to depict that tocilizumab can have an impact on the proteinuria and improvement in the proteinuria and the renal function test. But this is half the story. When we published this later on, that COVID came and the child was lost to follow up, and down the line, this child, when the drug therapy was stopped, the real story is my colleague Dr. Aditi would agree that we are struggling hard to manage this child because he has now developed CKD and almost needing a renal transplant. See, another complication apart from the kidney, this is one child who had developed significant mitral aortic valve replacement at the age of around 12 years because of ERA, and ERA, which is more common in our setting, can involve around 8 to 10% of the patients can have valvular involvement in our settings. So this topic again is very dear to me, but for today's evening, I want to sensitize the house about the lethal complication of what is systemic onset GIA, and this particular entity is nothing but a cytokine storm syndrome, where the immune system goes haywire and leads to a significant mortality. And the mortality in our series of patients is around 30%, and the global mortality is again around 10 to 30% of the patient. Again, the key is to diagnose this as early as possible, and the treatment here would be appropriate immunomodulation well in time. So this probably is towards the end of a child who is towards the end of the care of a child from our end, when we have nurtured the child, and then eventually everybody grows. And I'm thankful Professor Uma Kumar ma'am to join and her team, that we are in the process of establishing these transitional care services, and I'm deliberately using the word transitional and not the transfer of care, because of the fact that it's a continuum of care which has to go over time and not a one-point process. So as of now, we are in the process of taking it staged process during the time. So the road ahead and the key messages are probably, again, I would like to emphasize the fact that these are the preventable causes of disability, and what comes to it when it affects children is because of the fact that if a child gets arthritis, he is going to linger on it throughout his or her life. And that is why it is important to prevent these causes of disability so that they have a functionally independent life. Misdiagnosis, as highlighted in our presentation throughout, that often many of the patients, we can recollect from the slide of Megha that more than 50% of the patients were misdiagnosed as tuberculosis. And macrophage activation syndrome, often people feel that, just want to highlight the fact that macrophage activation syndrome can complicate any rheumatic condition, in particular systemic onset GIE, and it has got a high mortality. So early identification is the key. And if we look at the probably damage is because we are not yet able to give access to the effective drug in our setting, where it was only 11% of the patients compared to the 30 or 40% of the patients who are getting effective therapy. And by effective therapy, I mean the targeted therapy like biologics, which are available, and this can really help to curtail the burden of disability. And to come out with the shortcoming of this, we are working closely with the APLAR, which is the Asia Pacific League Association of Rheumatology, where we are working in developing the guidelines for this particular region, where the subtype of GI is different, the challenges are different. So this is all about our presentation, and thank you so very much everybody for joining. And I would like to acknowledge all collaborating department and register my apologies if I have unintentionally missed any of the names. Thank you so very much. And last but not the least, yes, please. Thank you for coming. Before you raise the question, yes, one point. One thing which we have been doing, not to a larger extent, but in some patients with arthritis, particularly monoarticular arthritis, we have been doing radiation synapectomy with your help. Sorry, I could not show that. Yes, go to me. Can give the mic.
Steroid is very good option because that will give us a long remission more than 2 years. There is no chance of infection in that because it is going to take care about the infection in all part of that. So I will say that you can start using the radiation for treatment. And what to point about going to Dr. Isha's slide, she has mentioned about the diagnosis of arthritis. I will also tell you about that. One thing has a good role to, if you have any doubt about the diagnosis of that. Number one. Number two, if you want to see the polyarticular involvement. Number three, if you want to see the responsible treatment, in all these options can be going to help you because whole body scan can be taken in 5 minutes. It is not possible with MRI. So I will suggest that you should start using all.
Thank you so much. All well taken. The only comment I want from you back is the risk of radiation.
No, there is no risk of radiation. There is no radiation leaking, and that is beta emitter which we are using for the radiation. Beta emitter have only 2 mm to 10 mm penetration. It will not go down. So there is no risk of radiation in this case. And number two, if you will use the radiation, you may not go for the immediate reach of radiation. You will not go for the if there is no rate, you will not mind it.
Any further comments, sir? House is open. Yes, sir.
We did with the joints.
Yeah.
Whatever it's 47. Somehow our experience is very less. Is it a cause of misdiagnosis or because the effect of the team joint does not have swelling? So maybe you're missing something, and maybe a regular team joint workup for these patients should be instituted. When you send the last patient of the AIIMS, I was pleasantly surprised. And because it was a small child, we could not do any joint arthroplasty evaluation. So I had to take a ethical committee clearance to do a total joint replacement.
I absolutely agree. Probably this is an underdiagnosed condition. And I do agree that probably we are not proactively screening these kids because by the time they reach this stage, it's too late. Yeah. So we will. Yes, absolutely. Uma.
breadcrumbs based on the original work. And yes.
I think now the turn for auto.
Everybody is behind you.
Yeah. So, for the town takes care of children, but I'm going to tell you, and I can tell you that we have come to you, and if they are not cured by you, they come to us, and they basically they usually require education. Some require knee replacement, and the youngest that we have done is around 14 years. 14 years old. We have so it's a wonderful operation. Dramatically changes the life, but again, they require the history involvement clauses. And in Western world, now the yield is coming down. I'm not sure if it's anymore, but it's now coming down. And it's acceptable options, and we usually now have grants for smaller sizes in Western. Wonderful. Actually, so obviously, two slide point in the presentation saying time. So, to be honest, I don't know what India is. So, yes, we are positive. That's not time. We don't only in time where we do releases of practice. I'm not really sure if there's any time. So, use it, methodology is good, but there is no time. One. Yeah, just one. The second thing is, it's a question to you. What is the youngest patient you have used with biological?
2 years.
2 years.
Even in non-JIA patients, in couple of patients who have, I remember one patient with autoinflammatory syndrome is around 1 year of age we are using.
Any precautions?
Typically, I think that as Pavneet was telling that the risk of tuberculosis flare is around to the tune of 3.4% in contrast to 0.1% in the Western literature. So typically, we'll screen all these kids for latent tuberculosis. Our protocol is to go for a MON2 and chest X-ray first, and if both are negative, then only probably we'll consider IGRA as well, just to be doubly sure that they are not having latent tuberculosis, and then move ahead with this. In case there is latent tuberculosis, we'll start them on INH prophylaxis and then start the biologics. Yes, please.
Very nice. Congratulations. I just want to know if there's a proportion of patients who become off.
Okay, good question. So, I mean, around we can say roughly 60 to 70% would be off drugs down the line, 2 years, 3 years, but at the same time, out of this chunk, 50% would relapse down the line, and that is why we need Professor Uma Kumar.
Is this like genetically?
Yeah, there is an increased preponderance of this, particularly monoarticular, I mean monozygotic twins, but no single gene has been identified, apart from some monogenic variant. Yeah. I thank Professor Rama for joining. Thank you, sir.
He came to OPD. I came in mind, just remind me and just say, I might come for a few minutes.
Thank you, sir.
We must take the contact.
Yeah. Actually, to be honest, my heart was wanting that a dean must be here in CGR.
And also, significant number of people are here today. Increase number and strength also. And with this issue, we nominated appointed their personality committee to look at the CCR and rounds how we can encourage residents, the students, and of course the faculty. Generally, what we see that the faculty of the concerned department and the research department become understood despite this being the every day. The entire afternoon. They don't come. We have repeatedly requested them that please do not go to the department in the afternoon. Encourage the faculty, encourage the residents. And I'm happy to see that Raj model is here, but I want to see that this all should be completely full and should fall short. That is, people are going for the bigger place, like we have sometimes look at the tutorial part when we go to the lectures. We should shift this from the lecture to the article. And thank you once again.
Thank you, sir. Thank you so much. Thank you so much for joining.